Hi, good evening. We will be doing now Grand Test 181, which is AIM based questions. So this is starting from question number 51. First question is T&M staging of breast carcinoma with positive bilateral supraclavicular lymph node. Very easy question here. If we were dealing with something like lymph nodes number and then it would have been like we would have meddled with N3A, B, and but straight away when supraclavicular lymph nodes get involved, it becomes a metastatic, a distant metastasis. So we grade it as that, and even bilateral. This is what they have given, not only left but bilateral. So this is metastasis and this is distant metastasis. So we would grade it as M1. But if it were different, so it's a huge topic in itself, which we'll be dealing in a detailed class with breast carcinoma. But the moment you see supraclavicular lymph nodes, that too bilateral, you go for distant metastasis. Moving on to the next question. Here, this is an image-based question, and they've shown if so. My little tip for doing these questions, which are image based, is you have to be very careful whenever there's a limb, an organ shown. You have to look around, you have to see what organ specific it is. So it is a foot and you can just trace it. There's a little toe there and then there's a big toe and the whole foot, and the whole ulcer is more towards the lateral aspect, not the medial, not the big toe but the little toe, the little finger, right, of the toe of the foot. So here we would like to rule out stuff. If it were a distal phalanx, that the ulcer would have been in the finger. If it were a paronychia, it would have been closer to the nail. It's not. So we have ruled out A and C. What are we left with? Infected ulceration plantar to the fifth metatarsal. Plantar, yes, because dorsum is the front of the foot and the plantar is this. So this is B is becoming closer to our right answer, and D is a very non-specific. Gangrene with underlying deep space infection. Gangrene would be different. You would have actually seen as a gangrene is. It's a discolored part of a blackish and dark. That would have been, if that would have been shown in the picture, would have been the right answer. So gangrene is a blackish, dry and wet gangrene, edematous and discolored, purple, black. Those are the foot, but this is an ulcer. So this is how, by ruling out other choices, you will get to the right answer. And this trick really works, always works, that whenever you see an image base, be very careful what organ you're looking at and then start ruling out things, because the choices would be according to the organ. So paronychia, no. Fifth metatarsal head, yes. Distal phalanx, no. Finger, it's away from the finger. Then this gangrene, no, because like I told, discolored. So question number 53. It's a 40-year-old male comes to an emergency with a stab injury to the chest. So it's a trauma, it's a stab injury, and now this patient is hemodynamically stable. Important key here while we are answering. There's a stab injury to the chest, still he is stable. If he were not stable, you would know what we are dealing with. And neck veins engorged, heart sounds muffled. So you know something is going on with the heart. Very carefully you would rule out stuff here which is related to the heart. Cardiac tamponade, yes. Why muffled? So they're asking wrong statement. Immediate emergency room thoracotomy is a right answer when the patient is unstable. This is the rule you should remember while answering all the questions. Echocardiogram should be performed to confirm pericardial blood, yes. Why? Because the patient is stable. Can we have a chance to perform an echocardiogram, which is done bedside, and we have time. This is all what is required. And then entry wound should be sealed with an occlusive dressing. Yes. Why entry wound? Because we can prevent pneumothorax, sucking in of the air. So yes, all these choices. Only thing which appears wrong is a B choice. So again, by exclusion. So AIIMS question is all about exclusion. You can see you have enough information in the question, but if you're scared, you would not be excluded, because you have to have a very working calm mind while performing these solving these questions, while performing and understanding what all can go in the question and what are the choices. So it's almost like matchmaking. And so this is how, there's no fact here, no, only things that you have to be, we have to stay alert when you're reading. If it were hemodynamically unstable, then the answer immediately becomes, the correct statement is then would have been the right statement, though other things would, incorrect would have been echocardiogram. So this is what I want. Now surgeon tells a medical student to tap the side of the face of the patient who just had a thyroid surgery. So the surgeon most worried about the damage of which vessels? They are big vessels. See, common carotid. If it were, this patient would have not been alive at all. If there was a common carotid which was injured, external carotid, again they would be different. You know, the things would have been, there would have been a hematoma. Internal jugular could be, and then superior inferior thyroid arteries. So we have to know, this is also a common sense question, but again there's a fact attached to it. What are these superior inferior thyroid arteries supplying? They're supplying parathyroid, and tapping side of the face is a particular test to elicit a very important finding. What is that? Is on tapping, this person would have they will display certain deficiency of calcium, that is tetany, sensitive indicator of a tetany. The tetany would be, there's a contraction or a jerk of the jaw, which is an indicative of hypocalcemia. So this is what is going on here. When you tap, there will be a jerk of the strong jerk or a contraction in the jaw, and this would display hypocalcemia, and this would display that these superior and inferior thyroid arteries, they are damaged and they are not supplying the parathyroid. So this is important thing to know here. So superior and inferior thyroid arteries, they supply parathyroid, and parathyroid is the one which is responsible for maintaining normal calcium levels in the body. And by tapping the side of the face, you elicit tetany, which is by jaw jerk or contraction of the jaw, sudden contraction of the jaw. And this would elicit that there is damage to these vessels, superior, inferior, and there is damage, ultimately damage to parathyroid, which has led to hypocalcemia. So detection of hypocalcemia. Calcemia. Right. So this is, so other arteries, they were too big and they would have led to more disastrous eventualities and endpoints. With common carotid being damaged, the patient would not have been alive. So moving on to the next question, question number 55. This is a young male brought to the emergency department in an unconscious state with a history of head injury. CT scan has revealed small multiple hemorrhages in both cerebral hemisphere with compressed basilar interns, no midline shift. So if there were a midline shift, you would have gone for extra hematomas, right? And contusions, hematomas, these are the things which happen. Cerebral laceration would not show up like this. There are multiple small hemorrhages in both cerebral hemispheres. So it's a very typical, not infarcts, because this is a person had a history of head injury. So you know you have ruled out multiple infarcts, and what you're left with is a diffuse axonal injury. They are the petechial hemorrhages, which is a very typical finding on a CT scan or a MRI, where there are multiple hemorrhages, petechial hemorrhages at the border of the cerebral, as gray and white matter in the cerebral hemisphere, and also, but there's no midline shift because it's on both the sides. But if there was a hematoma, you can have biconvex or a biconcave or a crescent shaped subdural or extradural hematomas. And there is something known as concussion, cerebral concussion, where there is no findings at all because the brain has just moved side to side in a skull in a closed space. So that is the patient would have lost consciousness, history of loss of consciousness, but no findings on CT. Whereas there would be very characteristic findings of cerebral contusion in a CT and laceration, but only DAI would have small multiple hemorrhages. So it's a buzzword, you should remember, small multiple hemorrhages. Petechial hemorrhages are seen in diffuse axonal. So even by the name diffuse, there would be multiple all over in both cerebral hemisphere. So by just reading it more carefully, both the cerebral hemisphere and diffuse, not a one single contusion or a laceration. For a simple question, just more attentive you need to be before you choose the correct answer. Here diffuse in both the cerebral hemisphere, and there's an axonal injury and characteristic is the petechial hemorrhages. So operation wherein the stump of the stomach is directly anastomosed to the stump of a duodenum. So there is a Billroth surgery, Billroth 1 and Billroth 2, where the gastrectomy is done, but to what part of the left stomach is attached, that depends whether it is 1 or 2. I'll tell you a little way to remember this 1 and 2. So when we say 1 and when do we say 2? This was question number 56. So when 1 is when duodenum is attached. Duodenum comes before jejunum, right? So jejunum is 2, after duodenum 1. So 1 comes before, so duodenum. Stomach is always, there's a gastrectomy done, and this part either gets attached to the duodenum or to the jejunum, depending on what is the order of duodenum comes before, so 1, and jejunum comes later, so 2. So you will never forget this when you remember like this. Billroth 1 and 2, right? So this is how you will remember 1 and 2. So 2 is stomach is removed and the duodenal stem. 1 is duodenum is attached, 2 is the jejunum that is attached, right? Now moving on to the next question. 12-year-old boy comes with pain and inflammation of the heel with the left foot, red streaks extending on the inner aspect of the leg. And he remembers removing a wood splinter from the sole of the foot from the previous day. So whenever there's vegetative wood, it's always streptococcal. Streptococcal infection type B is the one which is most very invasive, streptococcus, right? And this is the one which causes fasciitis, and this is what we would call these red streaks. So it's a very fast growing infection which happens in inflammation, streaking of the lymphangitic inflammation, and this can spread very quickly, and the mainstay of the therapy is that you have to start treating with penicillins and elevation of the extremities, and it could be more fulminant, could be limb threatening situation here, and can even require amputation. But very aggressive debridement is the way to go, because it causes myonecrosis, this fasciitis caused by streptococcus. Why other choices are incorrect? First of all, Clostridium perfringens is the one which is for gas gangrene, but there's no in this story, in this vignette, nowhere it's written that the limb is swollen, caused an ulceration, and has got some bubbles or any indication of that. And Clostridium tetani would have a different picture altogether, right? This is streptococcal infection, which is streptococcal cellulitis is a very common after a history like this, where he's telling some wood splinter, some vegetation, wood splinter. This would be the history like. And staphylococcal would more cause like pus and purulent stuff, and this, and more like boils. The history of boils is that, right? So moving on to the next question, 58. This is all are true about the condition shown in the image except. So one is incorrect here. So here you see is a breast with retracted nipple and edema of the skin around the nipple. So it's pudgy orange. Yes, it is. It affects lymphatics. Yes, it does. Overexpression of HER2 new shows poor response to adriamycin, which is incorrect. It's a good marker having an overexpression of HER2, and it has a good response to adriamycin, right? So, and then Van Nuys prognostic index. This Van Nuys includes size of the tumor, margins, pathology grade, and age in years. So this is a modified index which is used for breast carcinoma, right? So, and 5-year survival for Van Nuys prognostic index 4 to 6 is 100%. So based on all these, age, tumor, size of the tumor, margin, and grade, you would choose the correct answer here, right? But this is sometimes this is also a question when used, and what are the things in this index. So one is your age of the patient, another is the grade of the size of the tumor, grade, and the things which is not is the lymph node, right? There's pathology, grade, margins, and size of the tumor, right? And then you can have a 5-year survival based on this when use a prognostic index. Also important is that why there is puckering and dimpling of the skin, that is due to the involvement infiltration of the ligaments of Cooper, but the skin is due to obstruction of the lymphatics. So this you need to understand. If they had shown an image which had a puckering or dimpling of the skin, then the answer would have been the involvement of the occurs due to involvement of the ligament of Cooper. But here it is, since there is a edema and almost the skin is just involved, this is the drainage of the skin by lymphatics which get blocked. And so there's a putty orange appearance and overexpression, like we have told, there is good rather than a poor response to adriamycin. Now moving on to 59 question. It's a 43-year-old man which is hit with the face with a baseball bat and presents to the emergency with massive facial swelling, ecchymosis, elongated face. Right. So important line in this is there's a mobility of the middle third of the face on digital manipulation of the maxilla. When the maxilla is moved, there is a middle third which is moved. So it cannot be lamboid, cannot be odontoid, because it would have been more like a jaw, but it's the middle part of the maxilla manipulation, middle part of the face which is moving, and palatal split would have been different presentation, would be inside the so it is by exclusion Leaford 3. But then if it were given Leaford 1 and 2, then how would you have chosen the answer? So important things to remember in Leaford 1 is that the anterolateral margins of the nasal fossa are intact in 1, and the infraorbital rims are intact in 2, and the zygomatic arch is intact in 3. So this is important thing to remember, that so we're dealing with question number here 59, and we have Leaford 1, 2 and 3. Leaford was a French surgeon who had given this classification for facial injuries, and then they're still very valid and still used. It was done in year of 1869 to 1951. This was his time that he was there in 1951. Till 1951 he was there in this world, and he had classified into 3. So Leaford 1 is the one which is a horizontal maxillary fracture. It's a maxillary fracture, horizontal, separating teeth from the upper face. So teeth are here and there's an upper face which there's a separation here, right? So what is important, the line is passing through the alveolar ridge, lateral nose, and the inferior wall of the maxillary sinus, inferior wall of the maxillary sinus. When they say lateral margin of the maxillary sinus, then we go for 2. This is how you will remember. When they say the lateral or the, we talk of the zygomatic arch, right? Zygomatic arch would be 3. Whenever we talk of zygomatic arch, it is 3, but 2 is the lateral margin of the maxillary sinus, lateral walls, and the posterior alveolar rings. And important is it's a teeth at the pyramid base. Its separation is teeth at the pyramid base, and the lateral margin, you have to remember, of walls of lateral walls of maxilla, right? And in 3 you need to clearly remember that it's a craniofacial disjunction, and nasofrontal suture line. This fracture passes through the nasofrontal suture line, maxillofrontal suture line, orbital wall, and zygomatic arch. So it's high up, zygomatic arch, and nasofrontal suture line, and maxillofrontal suture line. So this is how you will differentiate between 1, 2 and 3. Moving on to question number 60. Question number 60 is an image-based question, very typical endoscopic finding they have shown, and even they have told the patient has presented with an odynophagia. So odynophagia is difficulty swallowing, and this is nothing but, these white patches are nothing but candidiasis. This is in an immunocompromised patient. When you do an endoscopy, you can, the patient who's on corticosteroids, the patient who has who's been having some cancers and metastatic cancers and has not been eating well and has immunocompromised compromised or is a case of an HIV positive or has a AIDS complex, those are the ones who would have such a scenario where they have candidiasis in the esophagus. The patient would present with difficulty swallowing. Others are incorrect. Why? Because this is not how it will look. Eosinophilic esophagitis would be more hyperemia. Barrett's esophagus, again hyperemia, would be lower down at the G junction, gastroesophageal junction, and esophageal webs are also different looking, and they are usually seen in anemia, and there are syndromes attached to it, right? So this white patches is a typical picture of candidiasis. Moving on to 61 question, is a 30-year-old man with a right-sided painless testicular mass. So whenever it is painless and it's an adult and scrotal ultrasound has also shown hypoechoic lesion, you know you're dealing with a carcinoma, you're dealing with a testicular tumor, and you never do an FNAC for it, you never do a biopsy. Yes, you can do serum markers, but definitive diagnosis, the question is very specific. They're asking procedures will require to make a definitive diagnosis. If it were how to screen, how to start, then serum markers could have been the choice, but high inguinal, this is how it is supposed to be diagnosed definitely, is high inguinal orchidectomy with ligation of the cord at the internal ring. This is how it has to be performed, and remember that this is, you do not want this cancer to spread, so you never biopsy it from the scrotum, you never do an FNAC of this mass. Whenever you palpate such a mass, you suspect this is a testicular tumor. Whenever it is shown on an ultrasound there is an hypoechoic lesion in the testes, very clear cut question and very clear cut information you need to know. You never biopsy it, you never do an FNAC. Everyone, each one of you has to know this, because it's a very important thing. Whenever there is a hard testicular mass, it is supposed to be treated as a testicular tumor, and you never perform a FNAC or biopsy it. You always do a high inguinal orchidectomy, and you would always go for a ligation of the cord at the internal ring. This is what you need to remember, that you never biopsy a testicular tumor. So the question number 61 is about the testicular tumor, and what you do for the testicular tumor is a high inguinal orchidectomy. You remove the tumor or do the testes, and you ligate the cord also high. At internal ring. This has to be known really well, and no biopsy or FNAC. And yes, serum markers you can do AFP, it could be AFP, right? Or you can do SCG, beta SCG, right? This can be also germ cell tumor, could be a seminoma, right? AFP could be high, could be a seminoma, and you can do also LDH. So these are the tumor markers, testicular tumor serum markers you can do, right? Now moving on to the last question, 62, which is Fogarty's catheter. It's an image based question. So why it is not Foley's? Because you know how Foley's look. It's a yellow or even transparent. Silicone is transparent, but it has got one single tube, and it doesn't have an end like this. Why? Because it has got two bifurcated ends, right? One for inserting the saline and the other for the urine to come out. And it's definitely not a Sangstaken tube, which is used for managing the bleeding from GI, upper GI tract. It has also got two tubes with it. One is a big cuff, has got a big cuff, and which is the one which will hold these vessels from bleeding out again, and it is and has got a way to inflate it, and the two tubes come out, not like this. It is a Fogarty's. Definitely. Why? It has got a balloon, it's thinned out, it's tapering, and it's got one opening, and the small inflate, it is used to evacuate the blood clots from the vessels, right? So this is, and it's definitely not a Ryle's tube, because Ryle's tube is also a different looking tube. It has got a single opening, and has various eyes on it, and has nothing like this, a balloon at the tip. So whenever there's a tip and a balloon and transparent and tapering, it is a Fogarty's. And sometimes they will ask what it is used for. It is used for embolectomy, to remove the clots from the vessels, right? So this is it.